think we all know that these people were absolutely instrumental in getting diagnostic ultrasound, especially for obstetrics and gynecology, to setting it on the path to where it is today. And actually, without the imaging work that they did and they pioneered, these people, Bill and Frank Fry, who worked in Illinois in the 40s and 50s, wouldn't have been able to start the therapy ultrasound that we know today, and we've built on their pioneering work. As Colin said, I've done a fair bit of work on bioeffects and safety. My PhD was looking at standing wave effects in the blood supply of a 3.5-day chick embryo. When I got my PhD, I knew more about the blood supply of a 3.5-day chick embryo than anybody would ever want to know. But the first report about bioeffects, I think, was in 1927 by Wood and Loomis in the Philosophical magazine. It was a wonderful paper. I recommend it to anyone. You've got Mr. Wood and Professor Loomis, and that's the sort of tone of it all the way through. And what I particularly would like to show you is that in this paper, which is written in a very discursive style, it's reporting the effects of ultrasound on animals, and it says, mice are less sensitive. A 20-minute exposure not resulting in death, and though at the end of treatment the animal was barely able to move, the recovery was fairly rapid. And this is an interesting bit of biology. Biologists inform us, however, that the blood count of a mouse is affected by fear, the corpuscles hiding in the liver until the damage is over. So if you want a bit of light bedtime reading, go and look at the first paper on bioeffects of ultrasound. So I'm going to talk about therapy ultrasound in what is really still an imaging ultrasound meeting. And therapy people all like to say, well, therapy was there before imaging. And if we look at a history, you can see that actually the first suggestion that you might use ultrasound for cancer therapy was from Sen-Gorgi in 1933. If we look and see what was happening in imaging ultrasound at the same time, it wasn't really until the late 40s that sonar-type medical ultrasound was being talked about and was being introduced. And as we go through the decades, you can see that therapy ultrasound, I haven't included the imaging because you all know about the imaging, but the therapy ultrasound has evolved in a number of ways. And this is actually a rather old paper now. Actually, the bottom of the slide is not there, but it was published by Mitragotri in 2005. And I show it just to show you the complete range of things that ultrasound can do if you turn up the power of it. And it ranges from the physiotherapy that I'm sure you all know about, and the high-intensity focused ultrasound that I'm going to tell you more about. But at very low powers, there's bone fracture healing. It's being used to see whether we can enhance gene delivery. It's being used to treat vulvar disease, a whole range of things that therapy ultrasound either can do or we're looking to see whether it can do. I've been around a while, and I've always felt that therapy ultrasound was the ugly duckling of ultrasound. I was tolerated, I gave talks about therapy ultrasound, and it wasn't really as glamorous as the swan of imaging. And what I want to try and show to you is that I think we've developed from an ugly duckling, and maybe we are now a swan as well. Some of you will remember, the older people amongst you will remember Professor Kit Hill, who was my first boss. And he had this idea that when you get new ideas, there's something, he kept drawing on a napkin in the coffee room, an enthusigram. So you have a new idea, and everybody thinks it's amazing, so you get this great swirl of enthusiasm for it. And everybody thinks it can do everything. But then it doesn't do everything immediately, and this was very much with me with therapy ultrasound. People would sort of pat me on the head and say, there, no. Very nice idea, you can play, but it's not going to work, is it? And after all, we all know that high levels of ultrasound on bone is painful. And then you get to a stage where people think, well, okay, maybe there is something in it. And you get to the level we're at the moment where there's a general acceptance that it will have a role. It won't be able to do everything, but maybe there will be some things that it can do well. And that's what I want to show you today, that I think there are things that therapy ultrasound can do well, and things that maybe you can use in some of your practice. So what's special about ultrasound? Well, we all know it has focusing capability. It's used in imaging, but especially in therapy, we can focus ultrasound. And because of the wavelength, because of the millimetric wavelength that we have in soft tissue, we can focus it very sharply. And we can design our transducers to give you a very long focal length. So the focal lengths can be tens of centimeters. So if you can focus it deep within the body, maybe it can be useful. We, of course, have the imaging capability. And so at low levels of ultrasound, we can image the body. And if we turn up the power, we can cause cellular effects and tissue destruction. So we have the ultimate seek and destroy modality, maybe. But is there anything extra? Well, there's a science fair out there, and you can, if you go and look at the infrared camera, you can see front-face transducer heating. We know ultrasound can heat tissue. That's been the basis of physiotherapy for quite a while. So what can we use tissue heating for? Well, as I say, physiotherapy, gentle warming of the tissue, stimulation of the blood flow for beneficial purposes. If we heat high enough, we get thermal ablation, and I'm going to talk a lot more about that in a minute. There is the field of hypothermia for cancer therapy, where you aim to get temperatures in the range of about 43, 44 degrees, maintain it for an hour, and get a synergistic effect between the heat and radiotherapy or chemotherapy. So you can reduce the dose of X-rays or of drug if you administer them to warm tissues. And drug delivery. There are now some low temperature, some liposomes that will melt at low temperature, and if you load them with a drug and get them to the tumour target and melt them with the ultrasound, that may be good. And if we have nonlinear propagation, as we almost always do with diagnostic ultrasound in tissue and with therapy ultrasound, you get enhanced heating because of the higher harmonic content, higher frequency content. We also have acoustic cavitation. We have three sorts of bubbles. We have collapsing bubbles, we have stable bubbles, and we have bubbles we've introduced, contrast agents. And they all have effects on tissue. If you drive them hard enough, collapsing bubbles will give you enhanced heating locally. They will change the permeability of a membrane locally, which may be useful for drug delivery. And in lithotripsy, you can use collapsing bubbles to break up stones. Stable bubbles, again, you can get changes in membrane permeability if you have a bubble vibrating stably against a cell membrane. And contrast agent microbubbles are used to change membrane, to enhance drug delivery by changing the membrane permeability, to dissolve clots in sonar thrombolysis, and they have a role in opening the blood-brain barrier. In some of my earlier years, I did some work looking to see the effects of cavitation on cells. So here you can see some survival curves. So a subharmonic index is an index of how much cavitation you have. So as we increase the intensity, you see that you have no cavitation. So this is increasing in this direction. So you get no cavitation, so you increase the intensity, suddenly you start to get cavitation. And you see a corresponding decrease in the number of cells surviving. So when you have cavitation in this medium, you start to kill cells. But if you do the same experiment under high pressure, so the bubbles can't vibrate, here you can see the number of cells, intensity this way, surviving fraction here. So if we do it under normal pressure, you get cell killing, very sharp amount of cell killing. But if you increase the pressure, you've got no cavitation, the cells will withstand much higher intensities than they will if you have normal pressure. So cavitation, we know, has effects on cells. I think that we were amongst the first to show that you could get cavitation in living tissues. It's been known for a long time that you can draw bubbles out of solution. That's decompression sickness with divers. That's gas bubbles being drawn out of solution. Did some early work with guinea pig hind legs, where we were looking to see these very bright echoes that we could see, which was bubbles being drawn out of solution by physiotherapy ultrasound machines. And more recently, and this is a talk some of you may have heard and I gave yesterday, I had a student who's actually just passed her PhD, Anna Tokarczyk, working with us, looking at rat mesentery, isolating these very tiny rat mesenteric vessels, flowing ultrasound contrast agents through and looking to see both at therapy levels and diagnostic ultrasound levels, looking to see the effect on the blood vessels, measuring cavitation as we go, and these are all indicators of the amount of cavitation activity. And this is at 5 megapascals peak negative pressure with contrast agents. You can see that this vessel is taking up fluorescent dye in the vessel. So we're changing the vascular permeability, changing the permeability of this vessel wall with this condition. Also at 4.3, a lower pressure than that peak negative pressure, you can see that we're still taking up this fluorescent dye. So that has, maybe that has implications for drug delivery, and looking also at the histology of these vessels. So we know that bubbles can be very important, and with therapy ultrasound increasingly we're going to try and harness bubbles for our therapeutic purposes. So we have heat and acoustic cavitation. We also have a class of mechanisms which we call radiation pressure and other mechanisms. We know as the ultrasound beam travels through tissue, we get tissue displacement, we get shear stresses and strains, and that's used in lithotripsy. We think this is the mechanism for the very low power therapy that we do that enhances bone fracture and some of the increased extracellular spaces we see and disruption of the extracellular membranes that we see on histology. Again, some of the work I did a while back, we exposed heated cells to ultrasound under increased pressure. This is what we call a survival curve. This is the response of the cells just to heat. If we expose them to ultrasound at increased pressure so we have no cavitation, you can see that the ultrasound without cavitation and with no increased heating has an effect of decreasing the cell survival. We're not quite sure what the mechanism for this is, but it's non-thermal and non-cavitation. I've been talking about ultrasound enhancing drug toxicity, and here you can see some work. These two on the right were done at 37 degrees, showing that ultrasound on its own, adriamycin on its own, and ultrasound plus adriamycin increases the amount of cell killing you get. This is adriamycin, this is doramycin, so fairly common cytotoxic agents. And this is similar work. This is using propylene hydrochloride, but at higher temperature. So the ultrasound enhancement of drug activity is not new, it's been around for a long time. What's different is that we're beginning to do sensible preclinical studies, and it's beginning to go into the clinic. But I've been interested in ablation, thermal ablation, in tissue destruction. Why would we want to ablate? Well, it's pretty well known that if you can focus energy, you can destroy things. I mean, Archimedes' mirror is probably the first example of this. The siege of Syracuse, the sun's rays, so here we have the sun being focused, was used to destroy the Roman fleet at Syracuse. So that's a pretty good demonstration of focal heat being destructive. And the Comte de Buffon did something similar with an array of mirrors to destroy haystacks to frighten the native Indians. So what we're doing, we're focusing ultrasound's power to produce heat. And this is HIFU, high intensity focused ultrasound, sometimes known as FUS, focused ultrasound surgery. The principle is very simple, and just to illustrate it here, you take a shaped source, in this case it's a reflector to harness the sun's rays, and if you put your tea kettle at the focus of that source, you can get your tea for free, or you can have a phased array. So here we are, we've got two reflectors, tea kettle here, making our tea in Tibet. So we do it with ultrasound. We have a focused transducer. It might be a single element focused bowl, or it might be a multi-element phased array. We use that to focus the ultrasound energy at depth within tissue. So here, schematically, we've got the liver, we've got a tumour in the liver, and this is the focal region. And if we turn the power up high enough, sorry, this is the beam plot for the physicists amongst you, so that you only got significant energy in the focus. If you turn up the power high enough, what we can do is we can ablate, heat the tissue at the focus, but we don't heat anything anywhere else. So we can come in through the surface of this piece of liver, this is a piece of abattoir liver, come in through the surface and just destroy this region. And we've looked with a number of techniques, electron microscopy, immunohistochemical techniques, ordinary histology techniques. If you do it right, there is no damage other than at the focus. And actually, if you look where it goes from white to red, at that boundary, you can see there's a very sharp demarcation between live cells on the right and dead cells on the left. And this is about 6 cells wide. So in theory, you've got a technique where you can come in through the skin surface, through the intact skin, and just destroy cells at depth. The mechanism for cell killing is primarily heating. We know from thermal biology that if you reach 55 degrees centigrade and maintain it for a second, you get instantaneous cell death. So the extent of that white cigar-shaped lesion is determined by the line, the contour at which you get that temperature or something equivalent. So 56 degrees for half a second or 54 degrees for 2 seconds. But, so that equivalent, we call it a thermal dose. In the centre, you're going to get much higher temperatures because you've got an approximately Gaussian temperature, bell-shaped temperature curve of a Gaussian-shaped curve of temperature across the lesion. If we do histology, we see right in the centre where you've got this very high temperatures, you may get tissue boiling, so you see holes in the tissue, and then you see heat-fixed cells. In fact, it can be quite confusing to the histologist or the pathologist. If you stain these cells, they say, well, you've done nothing to them. Well, actually, yes, we have. We've heat-fixed them. But that's difficult to see under standard microscopy. Here again, you see that very sharp, this is H&E stain, you see this very sharp demarcation between live and dead cells. And with an a marker for apoptosis, you see there is a very small, thin region of apoptosis at the margin. This is primarily a thermal lesion, but you're going to such high pressures that you will also get some acoustic cavitation. I came to this field from ultrasound hypothermia, so I was using 43, 44 degrees and using it in conjunction with either X-rays or drugs. And actually we got bored one day doing what we're doing. We just turned the power up and blew a hole in the end of our water tank, which is quite catastrophic, but it made us think, well, why don't we just do this instead of doing our 1-hour treatments and repeating them. So what are the advantages of doing an ablative technique? Well, you don't need, as long as you're above your 55 degrees, you don't need to know whether you're at 60 or 80. So the thermometry is not such a big problem, as long as you're above the threshold for thermal denaturation. When you do hypothermia, blood supply is a problem because the blood supply carries the heat away. However, if you can give your high energy very rapidly, the thermal conductivity from the blood supply doesn't matter. You've already reached your temperature for protein denaturation before the temperature is carried away. So, and we're talking about 1 second, 2 second exposures at very high intensities. Those of you who went to Michael Tonter's very nice lecture this morning about elastography will know that you can, and I'll show you this again later, that stiff tissue you can look at with elastography. And when you cook, if you think about cooking a piece of liver or chicken breast, when it's cooked it goes stiff. So maybe that's a very nice way of actually monitoring our treatments. And if you're killing the cells, you can only kill them once, so you can do it as a single treatment, and you don't need any adjuvant therapies. So if we go back to the beginning of HIFU, well, interestingly, it started in the brain. It's not the obvious place to start when you think that the skull is going to be quite a barrier for your ultrasound field. But the Fry brothers in Illinois were interested in doing neurobehavioral studies in animals. They wanted to selectively destroy regions of the brain and look at behavior. They had some interesting systems. In fact, they didn't have a focus beam. They had 4 planar transducers that they made confocal. And you can see that here, and this is a pan that holds the water, and you can see here a rabbit, and they exposed the rabbit brain by making a hole in the skull. But they could do it pretty well. But here you can see a lesion in the white matter of the brain, and here this is these are both caps. So what they could do is they could place the lesions quite nicely, but because they couldn't image in those days, they didn't have the sophisticated imaging techniques that we now have. So where are we now? Well, it may surprise you the number of patients that have actually been treated with HIFU around the world. We still talk about it as a new technique, and it is a new technique, but HIFU for prostate cancer was NICE approved. It, along with other techniques for prostate cancer, got NICE approval removed and is now approved in the context of clinical trial. But there have been over 40,000 treatments of prostate cancer with HIFU, mostly in Europe. Abdominal tumours, many of these have been in China, but liver, kidney, are the main things, the main organs in which tumours have been treated, and osteosarcoma, more than 40,000. And uterine fibroids, and that's approved, CE approved, and the uterine fibroid treatments have been going on in the UK. There's a device that will treat cervicitis, more than 800,000, and this is this is last year's data. It's probably twice this now in China. Allergic rhinitis, and then a number of other applications which are rapidly growing. So how is the ultrasound delivered? How is the HIFU delivered? If we look at the extracorporeal devices, they fall into 2 categories. It's all very well being able to destroy cells with this 6-cell margin between live and dead cells, but you've got to be able to guide your focus and make sure you've got it in the right place. So the 2 obvious ways of doing this are ultrasound and MR. I, of course, would like to do it with ultrasound, because you can do it all in one treatment head, and the advantages are clear. The imaging and the therapy beam travel along the same path. So if you get refraction, you get as much refraction in the imaging beam as you do with the therapy beam. You can do real-time imaging and monitoring of the tissues if you're using ultrasound. Of course, ultrasound has very high spatial resolution, and you have the potential to design a device that's compact with the imaging and therapy in a single treatment head. I'm preaching to the choir here, I know, but I think that ultrasound has a lot of strengths. And what would we look for when we ablate our tissue? Well, the clinical devices that are out there at the moment are looking for hyperechogenicity. When you get oiling in the centre of the lesion, you get very big bubbles which you can see on an ultrasound scan. Clearly, elastography is a candidate, and maybe ultrasound for monitoring. So here we have some of the extracorporeal devices. Top left, we have something called the Chongqing HIFU device. There are 2, and there's only one in this country. I mean, there's actually one of each of these in the country, and they're at the Churchill Hospital in Oxford at the HIFU unit. This Thoracion device was originally built specifically for treating the thyroid, but actually now they're using it for treating breast tumours. And there are a number of other devices, but interestingly, all coming out of China. We built our own device at the Institute of Cancer Research. Typical British science, sort of chewing gum and string. We had a plastic water bag on a thing, mounted on a frame with a transducer, single element transducer here. We swapped in and out. This is an old cardiac ultrasound transducer, but surprisingly we were able to target quite well. And we treated 75 phase 1 and phase 2 patients starting in 1998. Now, I said that you could image the hyperechogenicity. This is the screen that the user for the Chongqing HIFU device uses. On the left, you have any image you want to call up, a historical image, and on the right, you have the active image. You see this line along here. This is the line along which the HIFU focus is going to move. And it's pretty much real time in this video, which I hope will run. So here you can see the HIFU focus. It's coming from below and it's scanning through. This is a piece of abattoir liver. It's going to go there in one direction and it's going to go back on itself. Immediately afterwards you can see the bright up. So this is the hyperechogenic region. If you want to, you can outline it, you can measure the grayscale on that. And this is what it created. The sound coming in from here, you see it's very sharp demarcation still, even doing this line of scanning. No damage from the point of entry up to the focus. And what you want to do clinically is to paint out the area with these bright echoes. So here we have hepatocellular carcinoma. This is treated in China. You have to treat slice by slice, so the region to be treated is outlined. And you start at the back and work forwards, and the reason for that is if you're creating bubbles, we all know that ultrasound doesn't like to go through bubbles, so if you want to understand the propagation path, you'd like to have the bubbles behind your focus. So we start at the back, we work forwards, and like a child's painting book, I like to compare this image with this image. You see that we've got all the bright echoes in this image, so we know that that's treated completely. Michael showed this image this morning, but elastography. Cooked tissue is stiffer than uncooked tissue, so here we have an RF ablation, and this isn't HIFU, this is RFA, so we have an electrode in the liver. And if you look at on the elastography, you see as the heating progresses, the region of stiffness progresses. And this would be an obvious way of monitoring HIFU as well. But you can use, of course, you can use MRI. And the advantages of MRI are also obvious. You have clear anatomical imaging, even through bone. And of course, that's a problem with the ultrasound imaging. If we're behind bone, we can't get a good image. And MR thermometry is quite well developed and quite well accepted now. These are the commercially available MR guided systems, the main one being the Exablate from Insightec. And this is the one that's at St Mary's Hospital in Paddington, and there's one now in Hull as well. So this has been used mainly for uterine fibroids, but is also being used for liver tumours now. Philips have just brought out a system, the Sonaleaf system. And for completeness, I've included two systems for treating the brain, and I'm going to come back to that in a minute. Insightec and Supersonic Imaging have also developed a system. This one is commercially available. They're multi-element hooded type transducers that will allow you to get into the brain. So I'll come back to that in a minute. And on MR imaging, you can see the region that's being heated, and you can outline the region you want to treat. This is a uterine fibroid, and the machine will calculate for you the required thermal dose. So it's the thermal equivalent to 43 degrees for 240 minutes, and when you reach that thermal dose, it will give you a blue spot until you, so what you're aiming to do is to map out or paint out this region all in blue. This green region is being treated at the moment and hasn't quite reached the thermal dose that you want. And this is the Philips Sonaleaf system, which we're about to get at the Royal Marsden for doing some bone pain treatments. But maybe you want to combine the two and do hybrid NR ultrasound imaging. And I would recommend that you go to the next session, to the Young Investigation session, where Vicky Bull is going to be telling you about her very nice work on hybrid MR ultrasound image. And I hope she'll forgive me by stealing some of her thunder, but one of the things we've been doing is comparing MR and ultrasound thermometry. So here we have a gel, a phantom gel, which we've been heating with HIFU, and you can see the MR thermometry, you can see the hot spot in the middle of this gel. We've been doing strain imaging, which is the basis for ultrasound thermometry, and this is an ultrasound image, and we've got a system where we can simultaneously do ultrasound and MR imaging. So we can do ultrasound imaging in the bore of the magnet. We have an MR compatible ultrasound probe. So these can be done simultaneously. And if we move one over the other, you can see that they're giving you the same region. And this is very nice because the ultrasound, the MR thermometry gives you a way of calibrating your temperature on your ultrasound thermometry. And similarly, we're looking to look at elastography, comparing MR elastography with ultrasound. We haven't actually done that simultaneously yet, but here we have the ultrasound elastograms, and here we have MR elastograms using MR-HIFU, so it's using our HIFU pulse to produce the push pulse that we need to do the imaging. So that we're aiming to overlay these as well and to find out what we learned. But as I say, Vicky will be telling you much more about that in the next session. Okay, so we have a technique for destroying tissue. How will we go about doing a clinical treatment? Well, we destroy very small regions with each shot. It's only 1 or 2 seconds, but it's a small region. So what we aim to do is to paint out the tumour and a normal tissue margin, and the rule of thumb is that it's the margin that a surgeon would leave if he was resecting. So obviously that changes a bit whether you're looking at breast or liver or kidney cancer. So we look at, I'm just going to show you anecdotally some of the clinical results. We look at the liver. So here you can see a tumour that was treated. So this is the MR image, gadolinium enhanced MR image prior to treatment. And post-treatment you can see the region of ablation. Now remember, this is through the intact rib cage. We haven't done any surgery, so this patient comes in, has a very light general anaesthetic because respiratory motion mainly respiratory motion will move the liver a lot, and we want to be able to keep it as still as possible to do our treatments. This is from the European Institute of Oncology in Milan. Again, you can see a liver metastasis. This is the one that's treated. This is pre-treatment, post-treatment. Very nice demonstration of the hypoechogenic region that you get with your HIFU. PET CT before and 1 month after HIFU. So single treatment through intact tissue. And this Milan group is beginning to do some survival work. This is the results for 30 patients. Again, you can't actually see the bottom of this, but it's a recently published study. Probability of recurrence against time since treatment. They followed these out for at least 2 years. Here, the green line are HCC patients, and the red line are liver met patients. The kidney, here you see a tumour in the kidney that's treated at Oxford. This tumour here was treated. So pre-HIFU, you can see the MR contrast uptake in the tumour. 12 days post, you see there's no uptake, so we've destroyed the blood supply to that kidney. And this is another kidney tumour, exophytic tumour on the right renal, the right kidney. You can see here the tumour that was treated. And you can see on follow-up, 6 months and a year, there's no recurrence of that tumour, and in fact this patient is still alive 3 years on. So a single treatment, no surgery. Pancreas. It seems to be a very good palliative technique for treating the pancreas. Obviously a difficult organ to image with ultrasound. So here we have a tumour that was treated palliatively prior to HIFU and 3 days after HIFU. Some of the tumour was destroyed. And the nice thing was that this patient was morphine dependent going into treatment and morphine free following treatment. That needs a lot more work to be done. That's again anecdotal. The first study that we will do at the Marsden with our new solar-leaf system is looking at palliation of painful bone metastases. There's quite a lot of work in the literature now indicating that this is quite useful. So here you can see a temperature image. This is from Philips. Around this bone here you see the temperature rise there. And as I say, in the literature there's preliminary reports of a decreased, this is a pain score, the VAS score, days post-treatment. So you see almost immediate reduction in pain, which is certainly out to 3 months in this case. is maintained. What we think we're doing is ablating, you can't see the bottom of this, but ablating the nerves in the periosteum. So you can see here, very nice temperature rise just at the bone surface. Now the brain. Now that's, as I said to you initially, this is where HIFU started, but it was a bit counterintuitive because you had to raise a skull flap in order to get your ultrasound, the focused ultrasound beam in. But now, and this is one of the first brain tumour treatments that's been done recently. This is a young girl with a glioma. She had a skull flap already raised for previous surgery, so she had an acoustic window to the brain. Palliative treatment, very large tumour, 6 months after HIFU, you see there is a reduction. So quite a nice palliative treatment in this case. But if you don't have a skull flap raised, you need to do something rather clever to keep your focus once it's gone through the skull. And the answer is time reversal or adaptive focusing. And this work has really been pioneered by the Institut Langevin and Michael Tonter's group. In order to do this adaptive focusing, you have to have a very large element array. You need to have a large sort of deep bowl shape array. This one I think has got 1,056 elements. Oh, well, this one actually is one of their early ones with 512 channels. I haven't got time to go into the physics of adaptive focusing, but it is possible to send out pulses to see how the skull scrambles those pulses and then resend them so that you can reconstruct your focus. This is the clinical device that's been developed by supersonic imaging. Here you have your array, pretty sophisticated treatment planning. They've tested this in cadaveric heads, and you can see here that going through through the intact skull, you can get a very selective region of heating. Now, there are a number of applications for this. And one of the most interesting at the moment, I think, is the treatment of essential tremor. The supersonic system has not been used for treating essential tremor, but the system that's coming out of Insightec has. It's a very similar device, large multi-element array. You have to do this under MR guidance. You can't do it under ultrasound guidance because you can use the MR thermometry to check that you're not burning the skull, which is very nice. And you can target a region in the brain, in this case here, and this is work that's been done in Zurich. And here we have a patient who, prior to treatment, was asked to draw a line inside this contour to draw his spiral. And you can see that he really couldn't do it at all well. And he couldn't draw a straight line either. Immediately after treatment, this was his result. So this is a single lesion in the brain. So he was able to do this immediately after treatment. And the effect is long-lasting. So I think that's very exciting. And there are other applications for this, maybe epilepsy. If you can find the focus of the epilepsy, then maybe this, again, would be a single-shot treatment. Other applications. When you're treating the liver, or the kidney, or the pancreas, you have to go through the rib cage, and we know that ribs aren't very kind to ultrasound, so we need to look and see sophisticated ways of firing our multi-element arrays to get through the rib cage, and this is the basis of a large EPSRC grant, consortium grant that's held between ourselves at the Institute, University College London and Oxford. We're designing a treatment array which will allow us to have ultrasound imaging to get through the rib cage without causing a burn. So if we don't do anything clever, you see we have a high intensity, in this case pressure, on one of the ribs here. We're trying to fire through these ribs to something behind it. However, there are techniques that we're investigating where you change the way in which you deliver your sound. You see very much lower intensity on the ribs, but still getting the sound through the rib cage. And part of this grant is also trying to look how we can deal with the motion in the liver without anaesthetizing our patients. Another application, and one that we've got some funding for, is fetal transfusion syndrome, where you have a shunt vessel between the two babies. If you could destroy that shunt vessel, then maybe you could prolong the pregnancy. We've looked, this is a rat, you can see the femoral vessels of the rat. A single shot here will allow you to destroy that blood vessel and occlude it, and maybe that will be useful in fetal transfusion syndrome. And there are other applications for vascular occlusion, I'm sure. I've mentioned drug delivery a couple of times. The principle here is that you put your drug in some sort of a carrier, whether it's a microbubble or a liposome. You allow the blood supply to carry the drug to your target, and then you release it with ultrasound, whether you're using the thermal effects of ultrasound or the mechanical effects of ultrasound. And there's a company called Celsion that have produced Thermodox, which is a doxorubicin within a liposome, a heat-sensitive liposome. If you use contrast agents, there's quite a lot of evidence now that if you use ultrasound and contrast agents, you can temporarily open the blood-brain barrier. Now that's very exciting for getting drugs across the blood-brain barrier. You can do it in a number of animals. This is work from Clever Hunanen's group in Toronto. So going from the mouse to the rat to the rabbit, you can see regions where you can open the blood-brain barrier and get, in this case, contrast agent into the brain. The blood-brain barrier remains open for a while, but it does close again, so it's a reversible effect. And this is an example of doxorubicin in a liposome. On the right-hand side of the brain, there was no ultrasound. On the left, there was, and you can see uptake there. And these are tumour studies, fractional survival studies for tumours. And here with gene delivery, something similar. Here you have a brain. This is work from Heidelberg and Stephen Myers. The right-hand side of the brain was exposed to ultrasound, the left hand was not, and you can see the uptake, in this case of vital dye, and here you have an antibody uptake. So very exciting for the future. So where are we going with HIFU, or with therapy ultrasound? I think the future will give us smaller application-specific devices. We need faster treatments and better treatment monitoring than we have at the moment. This hypoechogenicity for ultrasound, it's beautiful when it works, but sometimes you get ablation without the hypoechogenic region. We need to be absolutely certain what we're doing. We desperately need clinical trials, we need patient numbers, and we need multi-centre prospective clinical trials. But that said, I think there's a lot of promise for it as day case treatments. It's not painful unless you're specifically treating a nerve. I think it has a huge use for palliative treatments. I showed you the pancreas. That's something I think we really should be working more on. And for the treatment of recurrence. Because we're doing such a localised treatment, we can go in and do the same thing tomorrow or the day after, and we're not affecting anything else. So it's not like radiotherapy or chemotherapy where you get a build-up of toxicity. Nostradamus got it right. He said that sound waves would kill cancer between 92 and 98. And we did our first treatment in February 1997, so he was pretty good. So I hope that I showed you that therapy ultrasound is no longer the ugly duckling of ultrasound, that it truly is a swan, and what's more, it's a swan that can fly. So thank you very much. There's lots of people who I have to thank that I've worked with over the years. My wonderful team at the Institute of Cancer Research, past and present students, and the HIFU unit of the Churchill Hospital also. Thank you very much.